Well, is he going to be able to be at this one? Damien, do you remember, is Robert planning on being able to attend this, or was there something that took him away?
I don't remember anything, Tom. I know he was out all during Christmas break. I haven't been able to get a hold of him. So
He's on.
okay.
Okay, great. Hello, Robert.
Hi. Yes, I'm here.
Great. Okay. It is 9:30, and we are going to start the January 3rd, 2023. Happy New Year's. OEB Strategies on Evidence and Outcomes Work Group. And I'll call the meeting to order. And our first, the agenda Rose has on the computer screen. We're going to, after we do our usual business of approving November's synopsis, we're going to ask our carriers to tell us about the things that they're looking at adding to the 23-24 plan year. So this is a significant, this is an informational session, and it's time for SEOW to understand the implications of what's being asked or looked at for adding, and for us to ask questions. And if there are additional types of information that we think the board will need, it gives us time over the next 3 to 4 months as we plan the renewal. So that's the reason what we're going to be looking at and doing today. Glenn is not here this week, but Margaret is filling in for him, I think. Right, Margaret?
That's right. Good morning and
Okay.
Happy New Year.
Great. Thank you very much. So,
and Tom,
yes.
Tom, just to chime in a note, so you're aware, because I don't know if you can see the entire list of participants on the meeting, but I did want to note there are a couple of members of the PEB board who have dialed in, I think, to listen in today as well. So both Andrea Foltz and Kimberly Hendricks from the PEB board are
Wonderful.
also on.
Welcome you two. You know, the ongoing collaboration is between OEB and PEB is, one, necessary, and two, appreciated. Okay, so with that, we'll go ahead and start. And the first order of business is the synopsis from November. Is there any questions or additions that people would like to make? I will point out that I think we had two actions. One was the addition of the diabetes measure as part of the dental presentation. I think it's oral screening for diabetics, and that will be put both in the OEB and PEB work plans. And then the second one had to do with at the next report, asking both Kaiser Permanente and Willamette Dental to share the demographics, some of the outcome and utilization data by demographics, specifically looking for health disparities. So any other before we go for approval? If not, I'll accept a motion.
So moved.
And
Seconded.
Thank you. All in favor, please say aye. Aye.
Aye.
Aye.
Aye.
Okay. So we're now on to the second agenda item, and we are going to be having Kaiser Permanente present to us, and we're going to be hearing about new changes to that delivery system. And so we have both Dr. Keith Bachman and Sapari Sturtevant to give our presentation. Is that correct, you two?
That is correct. Good morning.
All righty. All right.
Welcome and happy 2023 for all the OEB and PEB teams. So Sapari and I are happy to be here today to kind of go through what we're excited about at Kaiser Permanente in 2023, moving into 2024. And we kind of have some programs to talk about, initiatives and things that are dear to our heart and we think are going to be effective in taking better care of OEB and PEB members and taking care of all our members. Next slide, please.
And Keith, just to be specific, I know that when Glenn outreached to the carriers, it was what specifically is happening for the OEB population. And my understanding was what KEP's response was, this is what the presentation today is going to be, something that we are doing across all the program. Is that correct?
That's correct. That's correct.
Thank you.
So here's what we were asked to speak on today. Letters A through H, which are kind of, when we will go through with this as much detail as we can. We'll be kind of bucketing things into care delivery innovations, our virtual care program, health equity, which is near and dear to our heart, and certainly in our overall Kaiser Permanente operating plan as a major tenet, and then finally talking about importance of mental and behavioral health and changes in that going forward. Next slide, please. This is just a reminder, that we are different and we are set up under one roof with all the different parts of the healthcare system and a healthcare financing system all under one roof working together. And this is unique in the industry. This is how Kaiser Permanente is built, where in the community, we are part of many communities around the United States, but not every community. But again, it's on the ground, it's people, it's from our IT staff to our environmental services staff, to our clinicians, to our physicians, to our insurance executives and insurance managers that all work together, providing the best member experience to our members. And we really work across all lines of business, from Medicaid to Medicare to commercial insurance to ACA insurance. And really, we try to optimize for all of those. And we tend to do things, just like Tom was kind of alluding to, that are really in the best interest of our whole population. Our financing is different. We are a land for our really primary, more than 90% of our financing is in land 4B, which is a comprehensive population-based payment. It's capitated for the medical providers, for the medical group, which changes a lot of the incentives. So things are not done on a fee-for-service basis. They're really done with an eye towards efficiency and value-based care. And that's how we're designed. That's how we've always been. Before there was such a thing as a land model, before there was such a terminology as value-based care, that's how Kaiser Permanente has always operated, as a beacon of difference in a big healthcare landscape. Next slide, please. And we'll be talking about some of the things that are in care delivery. So one thing was urgency care, which really everybody knows. All the healthcare systems in the community and in the country have been pretty frayed and pretty exhausted related to issues around COVID, issues related to staffing, issues related to the lack of care or delayed care that people had, which led to an increased acuity and care challenges, and somewhat less preventive care going on during the midst of COVID. So one sort of canary in the coal mine was our urgency care program, which really was significantly struggling. But we got together, we looked at the data, we talked to our clinicians, we talked to our nurses, we talked to our urgency care staff, and we decided, how can we make some changes with this? So we really changed the workflow by decreasing the time for when someone walks in the door to they can see a clinician. That way tests can get ordered, people can be stratified in terms of risk, and things that are even more complicated can get started earlier. So we've been able to reduce appointment time by over 20%, and each urgency care is seeing more than 17 additional appointments per day. The overall urgency care volume has increased during this time. So we're able to get more patients through with less time due to a urgency care redesign model. It may not be quite so obvious if you're not a frequent visitor to urgency care, but the work is going on in the back end to get people through faster, be more rational in how we're doing that, and deploy our resources most efficiently. Next slide, please. Turning to the hospital and sepsis. Sepsis is the leading cause. This is the next slide. Thank you. Sepsis is the leading cause of hospital deaths, and we have really focused on that. And now our 2 Kaiser hospitals in the Northwest region are among the highest scorers in terms of sepsis care in the nation. These scores are about 30% higher, or 30 points higher than national average, and results in better outcomes, which is less deaths, less ICU stays, which of course, and less hospital days, which of course does lead to lower cost. Sepsis is essentially bloodstream infections, and we have our data systems organized to detect those earlier as somebody is developing these parameters, either on presentation in the emergency room or during their hospital stay. A team is activated, algorithms are started, treatment is given, pharmacists, nurses, and physicians are working together. I will note with all these care delivery innovations, one theme throughout them all is teamwork. In our model, with all the parts working together, we're able to use teamwork to provide better outcomes. Our hospitals are safe. Both our hospitals are Leapfrog A, which leads to less hospital-acquired infections, which also leads to lower rate of sepsis. So again, this is a team effort, using data, using our systems, able to look for sepsis on presentation. If the vital signs are changing in a negative direction towards sepsis, that will send some alerts out, which gets the teams activated to more rapidly identify sepsis and get people treated. Next slide, please. KP at Home is our hospital at home program. Is really the other groups are starting these, but this is really the most robust program in our service area. This is a hospital level care for many conditions in the right circumstances done at home. We've had, as of 2022, we had over 915 patients in the program. And when we did some pretty careful outcome studies, we actually saw higher patient satisfaction and higher communications with the care team and higher perceptions about the complexity of the transition home. Readmission rates are quite low, over 50% lower than in routine hospital care. This again requires a great deal of coordination with staff, including paramedics, infusion specialists, nurses, pharmacists, nurse practitioners, physicians. Physicians available 24 hours a day through a video link as our nurses, home PT, OT, home imaging, phlebotomy, and even home meals. So this is a way of dealing with fairly common hospitalization kinds of things like emphysema exacerbations, bad asthma attacks, common infections, COVID, obviously, all leading to ability to open up beds in the hospital. And, in Oregon, we have a hospital bed shortage. So by having 6 to 22 patients at a time, taking care of at home, that does open up extra beds for our members. And one thing we're seeing in the last couple of years is up to 30% of our hospital filled with non-Kaiser members due to overall bed shortages in the state. We'll actually go and develop a communication setup, bring Wi-Fi in to a member's home if they don't have adequate Wi-Fi already. So all this, the technology's there, patients like it, provides great outcomes, very low risk of complication and readmissions when this program is used. Next slide, please. And one final program we're working on with our highest risk members is those transitions of care, people going from hospital to SNF care and SNF care to home. We know that's just a very complex, potentially risky, labor-intensive time, but the time spent in deploying nursing resources, pharmacy resources, and physician resources to helping with those transitions has been quite effective at lowering readmission rates, decreasing the number of days in the hospital, and decreasing the number of the days in skilled nursing facilities with great outcomes. One of the complexities of COVID has been the difficulty discharging from the hospital with many residential nursing facilities and skilled nursing facilities not taking patients due to COVID or due to staffing issues. I will turn it with the next slide to Sapari to talk about some of our virtual health solutions.
Keith,
Yeah.
on that last one, I think it's been nationally identified, but also in Oregon specifically, that the lack of SNF capacity has resulted in prolonged length of stay and again, bogging up the whole system. Is that what I assume that's what this is to address, and how successful do you think you are with it?
Well, there's still the roadblock of inability to discharge because of SNFs and ICF. Sometimes they'll go on divert, or they won't be able to accept more admissions because of staffing or because of COVID outbreaks. So it can happen either way. The other thing is dialysis beds too has been. So now we have a handful of patients any given time. We never had this before, essentially in our acute hospitals on nursing status, not needing physicians every day, just waiting for placement. So that's been a problem. But this is also to help empty beds at the SNFs, get people out of SNFs when they can, opening up beds at that. So.
Okay, thank you.
Yeah.
All right, on to Sapari.
Perfect. Thank you and good morning. And just wanted to wish you and your families a happy new year and looking forward to connecting with you in 2023. So I get the luxury of talking about our virtual health solutions. I'm very excited about this. So if you can move to the new slide or next slide. Thanks, Rose. Okay. So our first virtual health solutions that we are rolling out is our maternity at home program. And actually, you know, this was piloted last year and we had approximately 170 members enrolled in the program. And now we are opening up this new care option to all of our members with prenatal and postpartum care. How this will work is that during your office visit, early in the pregnancy, our clinician will have a discussion with you to talk about your needs and preferences. And then it's a joint decision by the member and the clinician as to whether or not video visits will continue or will be desirable for the individual. So if this is the case, the nurse will reach out to the member and kind of talk through the toolkit that's available, and also to talk about, you know, when to call for concerns. So the toolkit includes, as you can see, a fetal Doppler, which will measure or detect the baby's heart rate, a blood pressure monitor, and a weight scale. And the monitor and the weight scale are actually Bluetooth enabled and can pair with a smartphone app and can send the readings directly to the member's electronic health record. So members who choose this option are still seen in person at regular intervals, of course, for their lab work, for their vaccinations, ultrasounds, so on and so forth. And they can request to change a video visit to become an in-person visit at any time. And, you know, and as I was thinking through or looking into this virtual solution, I was thinking that, you know, as a new mom, when I was a new mom many years ago, I think I really would have appreciated this option. It really would help to balance out, of course, you know, all the things that happen in life and of course the work case scenario. Okay, next slide. So optimized visits. This was launched in Q2 of 2022 and it allows members to see their personalized care reminders and to maximize the time that they are in the clinic. So our KP mobile app members who have provided a notification and location permission to us are welcome to an outpatient medical building via a push notification. So in this example here, you can see that this member is in our Cascade Park Clinic. And so when they select the Get More Done at Your Visit box, they can see the care gaps that they have outstanding, and they can choose to close those visits during the office appointment. And in addition to that, pick up any prescriptions when it's ready to be picked up. Any questions here? Perfect. Next slide. Another feature to support our members' post-appointment task is our after-visit summary notification. It can be overwhelming if there's a list of tasks for you to complete or follow up on after a doctor's visit. So an after visit summary outlining all of these tasks is currently available in our kp.org account. However, to support findability and to prompt actions such as medication fills or referrals or preventive labs and imaging, an after visit summary banner will actually appear on your kp.org app 5 days post appointment on your kp.org. And so this may be just a small action that we're doing. However, we will continue to look for ways to support our members in their health journey. And again, trying to make it as efficient as possible when they're in our clinic. Next slide. I'm actually going to have Dr.
Yeah, I mean, so we already heard one example of remote patient monitoring for maternity, and this is just 4 additional programs that are utilizing remote patient monitoring. I know it seems a little funny because it's like many people have been using, Bluetooth enabled blood pressure cuffs or smartwatches that automatically download heart rates and things like that for a while now. So it seems like, well, why is it so hard for healthcare to get on the bandwagon? And I would just say it is logistically complicated because there's all this data coming in. We need to have the infrastructure to both find the data that is meaningful and then have the teams of clinicians sort of organized to respond to that. So these are all high-risk conditions: congestive heart failure, high-risk OB, diabetes, that we are using for remote patient monitoring. All those programs are expanding. Our virtual cardiac rehabilitation program is pretty unique in our service area and has some really great outcomes. Cardiac rehab is something that somebody gets after an episode of congestive heart failure or after a heart attack or heart surgery. And by doing it virtually, people really don't have the driving to a therapy facility, and they really can be monitored. One of our cardiologists who works with the program was just saying how great one of her patients did, who she saw back in follow-up, who had lost a bunch of weight and lowered his blood pressure in his to the point where she needed to actually reduce and stop some of his blood pressure medications. And this was somebody she didn't expect was going to do that great with the lifestyle program. So again, these are 4 of our remote patient monitoring programs that are live, have been tested, and are being expanded in 2023.
So as you say, these are ones that this is a research project. These all have been shown in other situations to be cost effective and improve satisfaction.
Yep.
And what you're doing is trying to move it from research into a routine practice.
Yeah, and luckily we can leverage models going on in other Kaiser regions and pretty quickly adopt those when they've been shown to be successful. And similarly, we do something first that gets adopted elsewhere. Yeah. So these are all things that are going to be increasingly used in the future.
Okay.
And are currently ongoing.
And last question: how the fact that you are a capitated program, global budget, not tied to fee for service, how important is it, do you think, that funding leads to being able to do this? Because what I'm wondering is, how do you move these types of programs into a fee for service based world?
I would imagine most of these are pretty sound in principle, and if there was enough volume, a startup somewhere could develop a point solution to do any of those. But the difference would be it wouldn't be part of someone's general healthcare system. You would have 2 different or 3 different apps on your phone to go to for your blood pressure issue, for your diabetes issue, and for your behavioral health issue, as opposed to for all of these, it's all going to be done through one app called KP Ally, which then feeds into the medical record into kp.org. So that would be a difference. I don't think there's anything unique. It's not cutting edge in the technology. I think the technology is out there, but it's how do we apply it, have a good customer experience, and integrate that with the rest of their care.
Okay, thanks, Keith.
Perfect. And next slide. Thanks, Rose. So just wanted to talk about our e-visit modules. We have this in place today. Our current modules that are available addresses coughs and colds, allergies, women's health, dermatology, eye and ear pain. Just a quick example of this using this module. My daughter actually had an eye pain that actually just happened yesterday, and she came to me and said, you know, and I have to tell you this story because I mean, she's my daughter. She should know more. I should have explained to her more, but her first reaction was to go to urgent care. And so I suggested using an e-visit module because she's had this issue in the past. And I think fortunately, you know, in going through this algorithm, it kind of got her to the place where, you know, and she also had to send in a photo of her eye, of just that quick turnaround without having, you know, to leave the house to go to urgent care and to go through this module to get to where she was able to get a prescription from our physician. And because she's had this issue before, you know, it's in her health record, so it was a bit more more easy, more common for our clinicians to kind of prescribe and look at what she had. So, and next slide, just wanted to share some of the newer modules that are coming on board. So in October, we rolled out a COVID treatment, Toxavoid module for our members. And in November, because it's cold and flu season, we develop an influenza questionnaire. And then we also reintroduced our tobacco cessation program. And in 2023, so coming this quarter, Q1 of 2023, we are building an anxiety depression screening e-visit module and also a physical therapy module. And next slide, just wanted to share some stats with you. So the graph is really a snapshot of the breakout of our utilization between males and females. As you can see, about 76% of our e-visit utilizers are female and 24% are male. In addition, we have a live, it went live in December, an e-visit chat with an actual physician. So during your e-visit, if you needed to chat with a clinician, that option is readily available for you. Our e-visit demand in November, obviously it was really high, and it was high obviously due to the upper respiratory infection that people were getting. And our e-visit modules are being highly utilized. So as of December, we had over 92,000 e-visits as compared to, you know, the 73,000 in 2021. And we're projecting that this will continue to increase in the future.
Jeff, you have a question?
Yeah, could you go back a slide, please? So, Sapari, are you able to elaborate at all on the anxiety depression e-visit that's coming? Do you have anything more?
Yeah, I can talk about that. I mean, so I did it. I was just curious. We actually had it. It was up and running for a while in 2021, and then when there was a need to deploy more resources towards Paxlovid and COVID, it got pulled. But it was pretty successful, and it's a series of questions about depression, anxiety, substance use that you would expect that can lead to a prescription, can lead to a recommendation for other behavioral health programs or referral to mental health. It is reviewed. There are screens related to suicidality and other severe questions in there. And I will say, I thought it did a pretty nice job. It asked me some questions about trauma, PTSD, eating disorders, obsessive compulsive behaviors that I'm not sure I ask when I'm talking to my patients about depression and anxiety on a reliable basis, and also screening for bipolar and family mental health problems, which can have a bearing on treatment. So, I mean, it's not going to solve a problem, but it's going to move you with the appropriate next steps, which might include a prescription if it's straightforward, might include a visit with a PCP or a psychiatrist, might include referral to emergency psychiatric services or recommendation to go to the emergency room if needed. So it is, all these are reviewed by a physician, you know, very quickly after the questionnaires provided, and this keeps the flow of resources available to the member. Did that answer your question, Jeff?
It does. I just want to add, in my sphere of acquaintances, counselors, even though things have opened up, are doing at least 50% of their practice online. Their clients seem to really like that. And so I'm hoping that has helped with the access issues that we've experienced in the past.
I would say this e-visit program is more screening, assessment in a first step, as opposed to a conjunctivitis or a rash, which might be one and done.
Yeah.
And Robert, you're next up.
Yeah, thanks. Keith and Safari, can you explain the difference between an e-visit module and a virtual visit from the user end?
Sure. A virtual visit, it will be a video, usually a video visit, sometimes a phone visit, which you would schedule for anything, whether it's a follow-up, whether it's a new problem, and that's still available. We'll be talking about Get Care Now, which is our new video urgency care program. And so it's pretty open-ended. You start from anywhere. An e-visit is a little bit more structured, so you would start with a chief complaint or chief concern. My eye hurts, I have a rash, I need birth control, I'm having allergies, I'm having trouble with anxiety or sleep, right? And then it would ask you a series of questions to kind of go further. So if you're there for cough, I would say, are you short of breath? Do you have a fever? Or have you been exposed to COVID? Then it goes through a structured set of questions or a tree based on what you've done. You're clicking online to do that. It's gathering the data. And then it gets to the end, at which point a physician would review it, agree with the diagnosis, the proposed diagnosis, authorize any prescriptions that are needed or referrals that are needed. Or if it fell out and it clearly didn't make any sense, would contact you by chat or phone to take the next step. So it's an algorithmic structured visit, sort of automating or semi-automating the things that the usual kinds of conversations we have in the diagnostic interview we'd have in the office. Does that help?
That helps immensely. Thank you.
And you can sort of see where it's going. I mean, this is also going to be going everywhere, and you can certainly see how Amazon will want to be incorporating these into its kind of care that it will offer through its services, because it is efficient and members like it because it's available 24 hours a day in real time without any waiting at all.
Okay. Jeff, you still have your hand up. Are you done?
And Tom, we should get a time check too. We have we had a little.
We're good with time.
As in good as
yeah. If you have another 5 or 10 minutes, that's great.
Sounds good. Thank you.
Perfect. I'll pick it back up. I just have one more. If you can advance one more slide, Rose. So lastly, just wanted to, in the virtual care spaces, give you one more update, and that is our Get Care Now. Again, this is our live on-demand 24/7 virtual urgent care. It was launched in late 2021. Through Q2 of 2022, when we looked at some of the top diagnoses, so the top 5 included COVID-19, upper respiratory infection, cough, sore throat, and urinary tract infection. We've provided over 60,000 members with care through Get Care Now. And in 2023, we are projecting we will be providing care through this app to over 80,000 members, again, on this platform. As of Q4 2022, some good news, we are now licensed in all 50 states to deliver care to our members. This would be great for our members who are traveling or students who are going to school out of state. Okay. And next, I'll turn it back to Dr. Bachman to talk about our health equity initiatives.
Awesome. So health equity is really part of our founding principles, and we are not going to back off on that. It's kind of Kaiser Permanente nationally is focusing on health equity as we are in our region. I will give credit and some pride for the Oregon Health Authority, OEB and PEB, for pushing this issue as a customer group. And Safari and I are always known to be the people asking the hard questions at the national level, and they are acknowledging that the OHA-related groups are really cutting edge and a leading indicator for where the whole healthcare system needs to go in terms of looking at health equity, the health equity lens for all the work that we do. We have had for several years culturally competent care delivered through our Salud en Espanol program and our Genders Pathway clinic for gender-related care. We've seen good outcomes from those. and we will continue to support those. We are developing at Interstate, where I work, a Black Center of Clinical Excellence program as well in 2023, where we're currently recruiting physicians with expertise to work in that program, and we're excited to use that as another platform for improving health equity. We know that culturally competent care, and when the care is delivered by a clinician that comes from the community or looks like the member, we know that care is often better and those outcomes are demonstrable. So our commitment to health equity also goes in really rigor in recruitment and hiring and mentoring clinicians from all kinds of backgrounds and other staff members as well. So this commitment, we just know we're with you on the journey for health equity. We know we have a long ways to go to reach a state of health equity, but know that we are looking at it, looking for health disparities and specifically doing programs to help remedy them. Next, social determinants of health screening is happening regularly. At the time electronically prior every primary care visit, where people are getting questions about their social needs, and then we're able to link them and remedy them with our navigators, our resource action centers, and other ways for that. One thing we're doing, combining medical and dental, is having some mobile clinics for uninsured individuals and other communities in the Northwest. And that's kind of outside our main delivery system, but we're also going to be able to use it to fill care gaps and bring the dental care and medical care where they're needed. That's a partnership with Medical Teams International. Next slide. And then the community resource directory is, we can forward that link around to that, and that is through kp.org, but not part of the private space with that. And this is really what our navigators and our social workers and our physicians and our ER staff were using to help people find resources in the community. But now we're proud that it's really available to anyone. We're still using it's part of it's one end of the Thrive Local program, which is both the resource finder and then resource linker, and then that bi-directional communication between community organizations and the healthcare delivery system. With that, I'm going to turn it to Sapari for discussion of mental health.
Yeah, just a couple things here. Next slide. We wanted to give you some stats on our Ginger IO, which we launched in June of 2022. This application supplements our virtual therapy options, offering a greater diversity of providers and also expanding timely access to our members. Since this launch, we have over almost 2,400, as you can see, registrants. The top utilizers fall into the 45 to 64 age band at about 34%. Followed by the 26 to 34 and 35 to 44 age band, each at 25%. In addition to that, we have approximately 84% of our utilizers are female and 20% are male. And we are seeing some nice progress and improvements using this apps. 49.3% saw improvements in anxiety and 48.7% saw improvement in depression. And next slide. Wanted to tell you about our mental health appointing. So starting in November of 2022, our members can now schedule appointments directly into psychotherapy services via our member services call center or online without having to speak to an additional clinician. So really the goal behind this change is to make it easier for our members to schedule mental health appointments and to get care as soon as possible. Our members can self-refer for mental health therapy with a Kaiser Permanente provider, or they can contact a provider in the community, so no referral or intake is needed to schedule. In addition, just a reminder that our behavioral health consultants are still available in our clinics for same day and next day appointment access. And lastly, Michelle Teeples, who I know has presented to this group before, she is our senior director leading our mental health and addiction medicine efforts, will be more than happy to report the data points from this initiative in our future meetings. And then Dr. Bachman, want to end us with dental?
Yeah, just We continue to believe in medical dental integration as a model of care that provides better outcomes all around. We certainly know some people tend to see the dentist and not the medical office, and we can get their medical care gaps, immunizations, scheduling for preventive services done in the dental office, and vice versa. So it really does matter. We also know that dental care is really a leading indicator for social needs and social determinants of health, with large amounts of disparities related to that we see in dental care. So it's another place to bring in that social determinants of health to our work. Really proud that the dental team was very active in giving vaccinations related to COVID and are also giving flu shots at times as well. So we think this is unique, important, one of the few models really in the country with such high levels of medical and dental integration even for our commercial members. So the numbers there are the care gaps that were closed in proximity to a dental appointment by the nurses that work in the dental offices, and then by the staff in the dental offices able to give flu shots. With that gets us to the end of our presentation, and thank you for listening. Thank you for hearing our enthusiasm for what was a challenging 2022, and I'm sure it'll be a challenging 2023. But despite the challenges that we're all aware of, reason for optimism and enthusiasm for the new and innovative programs that we're bringing to our members.
Thank you, Keith and Sapari. Any questions or comments from SEOW members? Okay. Rose, on our agenda, we have a break scheduled now. I'm not sure if we need a break though. Does anybody need a break? If not, I'm going to suggest that we plow ahead with Moda's presentation.
Great. Well, thank you, everybody. First, I just want to say thank you so much for having us here today. We're really excited to talk about some work that we've been working on for the last year or so, and also talk to you about some exciting programs that we'll be proposing for the 23-24 plan year. So first, before we get started, I just wanted to introduce the MODA team because we do have someone new with us today. So first, I'm Erica Hedberg. I'm the Director of Government Programs for MODA. We also have Kara Stoudemire-Phillips, who's our VP of DEI and Community Initiatives. We have April Canetto, who is our Director of Population Health. And we have Dr. Popowich, VP and Chief Medical Officer for MODA. So first, we're going to get started doing an update on health equity and social determinants of health, because that's going to provide a really good basis for the programs that we'll be proposing. So we're going to toss it on over to Karis to get us started.
Thank you so much, Erica. Good morning, everyone, and Happy New Year. So we will get going here. Okay, so our first slide talks about our health equity roadmap. And our goal and our commitment in our health equity roadmap is driving better health through health equity. So we're going to walk through these three photos that you see here. So first, number one, these are our three focus areas. So in priority. So number one, our members. And this includes data and intelligence, always quality first, and social determinants of health and operations. Our second area, providers, provider incentives, clinic support, social determinants of health, point of intervention. And then we're really excited about this third area, this third focus area, which is community. And what you'll see in that area are some new innovative ideas that we're going to share about later, but I'll just give you those titles: Community Health Food Initiative, Volunteer Alignment, and Exploring Equity Zones. So these are the three focus areas for us in our health equity roadmap. Again, members, providers, and community. Next slide, please. This next slide is a definition of what health equity is. And there's a lot of different definitions out there on what health equity is or is not. We have adopted using the Robert Wood Johnson Foundation definition for health equity. We believe that this is very all-encompassing and really defines what we believe is the goal of achieving health equity. And I'm going to go ahead and read this one to you because I really want folks to listen to this one and understand it. Health equity means that everyone has a fair and just opportunity to be as healthy as possible. This requires removing obstacles to health, such as poverty, discrimination, and their consequences, including powerlessness and lack of access to good jobs with fair pay, quality education, and housing, safe environments, and healthcare. So as you see, as I said, it's all encompassing, and all of those factors are social determinants of health that feed into health equity outcomes. I know that many of you have seen the different diagrams that talk about equality and what equity is, and some of them have been there's a little one that's out there, there's a little boy that's looking over a fence, trying to look at a baseball game. This one, we really like this, this example. So this is the one that we've chosen to use in our commitment. So equality, everyone gets the same resources. Sounds good, right? No, we want to move over to equity, where resources are distributed to reach an equal outcome. So you see the difference there, where you see those stools or benches that the individuals are on. Equity is our goal. We just don't want equality. We want equity. Next slide, please. Now, here's a real life example of health equity, and we just wanted to share this. So do take a look at this, and you'll see that it is the social determinants of health that really feed into how health equity outcomes. So you look at the life expectancy compared to Hispanic females, white females, Hispanic males, white males, Black females, and Black males, in correlation with years of education. And we really felt like this was, as we were thinking about different examples of this, we really felt like this gave a really good picture of how social determinants of health really interface with those outcomes for social equity. We just ask that you look at that and think of this as something that we are absolutely considering in everything that we do. And this is an interesting one. We'll go ahead and go to the next slide. I know I spent a lot of time on this one as well, but you have the packet, so you can go back to it. Okay, this next slide, disparities in health outcomes. I want everyone to go to the bottom of this slide. Look at the roots of inequities. And we're going to read all of them because these are really important. These are the root causes. Environmental toxins and hazards, poor quality of care, discrimination, housing, poverty, food provider implicit and explicit biases, poor quality of schools, racism, and being uninsured. These are all the root causes that create the outcomes that you see on the branches of this tree. Those disparities in health outcomes include diabetes, cancer outcomes, infant mortality, obesity, heart disease, malnutrition, smoking, substance abuse. It is so important to understand that these root causes cannot be separated from these health outcomes that create these disparities. It is these root inequalities, inequities that create the disparities in health outcomes. And that is our goal, is to combat these root inequities and increase health equity to have better outcomes and less disparities. Thank you, and I'm going to pass it over to my colleague who's new to you all, and you'll be very interested in what she has to share, April.
Hello, everyone, and thank you so much for giving me the opportunity to have a chance to meet with you. I'm beyond excited at what we're proposing and what we're really working on from an innovative perspective within MODA. And really what Karis has been describing to you all it really helps set the context for what we're going to be talking about here in a minute in terms of what we're going to be focusing on and proposing as we move into 2023 and beyond. And we really want to ensure that we're all on the same page in terms of why and addressing those root causes, because that really is what is shaping the recommendations that we're putting together as we move more towards a sophisticated approach to health equity within MODA. And so when we're talking about the social determinants of health, I really just like this language here because it's lay terms, right? It really just helps us break down and understand. And these are all things I'm sure that you all really have a strong sense of, but it just helps us really just get kind of the same language being used universally across all of us. And again, this is what shapes the programs that we're designing within MODA. And so it starts with, health starts long before we're sick. It starts in our homes, our schools, and our jobs. And so when we're thinking about the strategies and the interventions, we have to be thinking about how we're going to be targeting where people live, work, play, learn, right? As you can see on number 5. And so a lot of this really coincides with not just what the intervention needs to look like, but where the intervention needs to occur if we're going to really focus on SEOW and move kind of upstream to then move towards health equity. All Americans should have the opportunity to make the choice that allows them to live a long and healthy life. And that's regardless, to Karis's point, of education, income, or their ethnic background. An individual's neighborhood or their job shouldn't be hazardous to their health. And what we see over and over again is that your neighborhood really does define your health. And that's what we're working on trying to really focus when we're talking about our community strategies that we're going to talk about here in a minute. And then the opportunity for health begins in our families, our neighborhood, schools, jobs. So you see a lot of the same terminology being used over and over. And really just when you summarize all of this, it's saying we have to go to where the people are and focus on their environment in order to really affect change and start to address health equity. You can go ahead and go to the next slide. I'm not sure if you all have seen this before. I like to iterate this or, just really emphasize this. Because, we often think that when we're looking at intervening within health, we're looking at that bottom 20%, which is access to healthcare and the quality of healthcare. But truly, 80% of what determines our health has nothing to do with our access to health, with our access to care and the quality of care. It has to do with socioeconomic factors, our physical environment, and our health behaviors. And so, again, when we're thinking about what is it that we want to do to actually influence an individual's health, if we're truly going to have a sustainable impact, we have to focus on that 80% while ensuring that we're sustaining the 20% around access and quality of care. You can go ahead and go to the next slide. So, this is to help paint the picture of what is the difference, or why is social determinants of health and health equity, and kind of how are they interrelated. And I really love the visual of this. What you can see is that as you move from the right to the left, you move more and more upstream. What we're going to be talking about in our renewal, and as we move more and more into 2023, 2024, and 2025, is going to be focused on starting to move more and more to the left. Because what we know is that if we focus on the structural determinants, which, as you can see, are things around, socioeconomic and political context, it's things like governance, it's how our policies, zoning laws. That's really, truly where a lot of the root causes happen when we're talking about health inequities. What we're going to be focusing on in the short term is looking at things around socioeconomic, right? So how can we support looking at things related to race and ethnicity and ensuring that we're tailoring interventions in a very culturally sensitive way? How can we focus on things around income supports and social determinants of health related to food insecurity? That we start to get, upstream there, but not as upstream as when we go all the way to the left and we look at policies. And then when we go even more to the right, it's a little bit more of an immediate, right? It's the material circumstances. You're going to hear us talk about some of the opportunities that we have to influence in that sphere currently, looking at behaviors, biological factors, the health system, and psychosocial factors. So by influencing the continuum of this, we will get to the goal of health equity. The further to the left we go, the more sustainable the change will be. You can go ahead and go to the next slide. So what does this mean within MODA? And Karis gave you guys a preview of this, and we have this slide in here twice because this really does frame what we're looking at doing in our 2023 as really kind of the underpinnings of our work around health equity. And so within the member space, I'm going to give you guys some details here in a minute around what we're going to do around health equity dashboards, looking at populations by race, ethnicity, geography, benchmarking them, to understand where we have differences in performance for OEB members, and really focusing on specific interventions in those areas and with those members where we see differences in outcomes based on those different demographic factors. Quality first is something that really drives the philosophy and the mission of MODA, but it's how do we incorporate health equity into that lens? And so we're going to talk about, when we're looking at PDSA cycles and quality improvement, how we're actually doing it specific to demographic factors where we have variability in performance, and how we're going to intervene within that and focus our PDSAs in those areas as well. And then all of our social determinants of health strategies that we're going to be proposing around our members, and the operations that have to happen within every department at MODA in order to truly start to move upstream. We're going to talk about provider. So the thing about health equity is it can't be within one silo. If we're truly going to impact health equity, it has to be across member, provider, and community. It's a sophisticated, complex approach that has to happen in order to truly get to health equity. And so within the provider space, we're starting to talk about equity-based contracting. What does that mean? How do we hold the hand of our providers to provide them support within their clinic when we're looking at differences in performance on their clinical panels? How do we then incentivize them to ensure that they're supporting and culturally tailoring their services in an appropriate way? And then how do we give them the tools, right? How do we ensure that the providers have the tools that they then need to be able to provide supports within their clinic? And then to Karis's point, in the community space, how do we start to align our volunteer opportunities with where we want to have a larger footprint around SEOH in our neighborhoods and health of our neighborhoods? So we're going to talk about food and how food initiatives are going to be able to align around our members as well as within our communities. We can go ahead and go to the next slide. And so what does this actually mean from an operational perspective? So really, and Kaiser, I love what you said as well about how this is a part of just who you are. It's a part of what health plans, it's a part of their DNA. It has to be in order for us to be successful. And so when we're looking at health equity at MODA, what we're talking about is data, integration, intelligence, and then accreditation. And so what we're proposing for 2023 from a data perspective is to really enhance our data capture as it relates to health equity and social determinants of health. So what does that mean? I know you guys have heard a lot about MODA 360 and the work that's being done with MODA 360 to capture SDOH as well as race and ethnicity and other factors. We're also in the process of adding indirect data into that. There's only so much data that we're going to get from members directly. There's always going to be a gap that we have to be able to address. So what are some other data sources that we can pull in so that we have a 360-degree view of all of our members at a population level and can actually analyze that data? And then how do we streamline all of this into our systems in a meaningful way? There's a significant amount of work happening at MODA right now within all of our different systems to ensure that we have the correct capturing of the data and the flow of that data so that we can actually move into intelligence. And so I'm going to go a little bit out of order here. So when we go from data, then it's moving into intelligence. So once we have the accurate data capture, which we're working on in 2023, and have already started, then it's moving into, okay, what do we do with that data? I've done health equity work for a really long time, and it's just population health work in general. And there's so much information to look at. We have to have a way to distill that down and make meaningful, actionable decisions that truly drive health equity. So what does that mean? So what we're looking at doing is actually designing a health equity dashboard. So what that will do is it will show us at a population level where individuals within OEB live and how their performance based on race, ethnicity, geography, different, non-English languages spoken, how their performance is better, worse, or the same as a benchmarked population. And on a dashboard, we would be able to look at zip codes. And that goes to what Karis was talking about, is starting to explore health equity zones to really understand where do we have an opportunity to start to pilot some work in specific areas with specific populations that's really about population health and improving health equity. And so the dashboards that we're talking about is something that we're proposing that we would implement in 2023 to design and then go ahead and operationalize and have live by 2024. We also want to be able to produce baseline reporting for OEB so that we can come and show you, here's what your population looks like based on these demographics, broken down by HEDIS, broken down by utilization, so we can understand, again, against those benchmarks, where do we have different impacts as it relates to cost and quality, and where should we be focusing our quality improvement strategies, that we're very proactive and deliberate about how we're designing our work. And then through that, we'll be establishing annual benchmarks based on that benchmarking, where we sit now, where we want to be year over year, and then showing you guys our progress on that as it relates to our quality improvement plans. We're also working on integration. And so proposing that is something that we're really going to be focused on in 2023. So things like holding our vendors accountable. This work can't start and stop with an internal department within a health plan. It has to be fully integrated into everything that we think about from an operations perspective. So when we're looking at vendor contracts, all of our downstream entities, how are we holding them accountable to health equity? Are they reporting on differences in populations that they're serving? Are we asking them, to actually improve their performance based on benchmarking and differences? So that's what we'll be doing in 2023, is starting to incorporate that into our contractual language for all of our downstream entities. We're also going to be establishing SEOW interventions. And I'm going to talk about that on the next slide and what that's going to look like around our healthy food program. And then implementing actual performance improvement projects specific to health equity. So once we've identified those benchmarks and where we want to have improvements, doing some pilots that really focus on specific quality improvement and utilization reduction projects specifically around equity. And then all of the alignment of that with our MOTA 360 and Care 360 and our population health equity work. The last piece of that integration, I talked about it a little bit on the clinical slide with our providers, but it's moving into equity-based contracting. And there's a lot of opportunity in this space nationally, and especially, within our region as well. But as we start to think about how do we really work with our providers in a meaningful way, again, we can't just do this within a department, within a health plan. If we're going to impact health equity, we have to bring our providers along with us. So it's looking at our higher volume providers initially. It's looking at their clinical panel. It's identifying where they have inequities occurring on utilization and in quality, and then working with them to actually incentivize them to reduce that gap in performance. And then I'm really excited to talk about accreditation. So one of the things that we're going to be doing, or we're proposing to do in MOTA in 2023, is to build our foundation for health equity accreditation. And I don't know if you all are familiar with health equity accreditation from NCQA, but it's a product that came from what used to be multicultural healthcare distinction, and now it's evolved over into health equity accreditation. And it's a set of 6 different standards that health plans have to go through and show and prove that they meet the requirements. And it includes the how robust our race ethnicity data is, our integration of SEOW, everything I've talked about in terms of our systems and our intelligence and our dashboards and our quality improvement projects are all embedded within the health equity accreditation product for NCQA. And so what we're proposing is that we actually use that to help build out our foundation, and then we would obtain the accreditation in 2024 for our commercial product. You can go ahead and go to the next slide. Then lastly, from an SEOH perspective, right, we talked about how social determinants of health are at the root of what we need to do to focus and really drive towards health equity. What we're proposing is to really start to have a very large footprint in one key area of SEOH, while we continue to build out all of our other work around operations and coordination and resource support with our members. So what we're really looking at doing is building out a food program. And we've done a ton of research on this. And we know that when we're looking at populations, especially populations with chronic conditions, such as diabetes and hypertension, and populations that traditionally have been disadvantaged, right? So when we're talking about by race, by ethnicity, or by where an individual lives and their lack of access to quality nutritional food, this is an area where we can save a significant amount of money for OEB, as across our health systems, because we know that food really is medicine and drives health outcomes, while also ensuring that we're facilitating long-term health of our members. And so what we're looking at doing is having a transitions of care medically tailored meal program for type 2 diabetics. So diabetics who are inpatient for over 24 hours and discharge home would then receive a certain number of medically tailored meals delivered to their home. Additionally, then they would be eligible along with a broader population for our full food as medicine program that we're proposing. And Erica's going to go into much more details about this, but at a high level, it will also be targeted initially in 2023 for type 2 diabetics. And it will be a program where your OEB members will be able to actually receive matching dollars for healthy food. as well as health coaching programs and nutrition programs, how to shop for healthy food, how to cook healthy food. And it would be something that would be available for the family unit and not just for the individual, because we know that behavior change requires really happening within the family and not just within one individual. If it's for example, a mother who has type 2 diabetes, she's not going to be able to change her eating if she's preparing separate meals for herself than what she's preparing for the rest of her family. So the Food as Medicine program will broaden our ability to support our type 2 diabetics and really integrate healthy food as a medicine program. It will also then support them with our VERTA program, which will be a way for them to get really a strong ROI, proven evidence around a healthy food digital application where they'll receive real-time coaching in addition to the food that's delivered to them. And that's that nutrition management program. We're also proposing enhancing our language services. That's really a foundational piece when we're talking about health equity. We have to ensure that we're providing care to all of our members, regardless of their nation of origin or language that is spoken. And so we're proposing that we enhance that to be providing clinical coverage for interpreter services. And we would do a very broad and detailed outreach campaign with our providers and our members related to that. And then we're also proposing flex funds that would be accessed through our population health team, where if an individual with an OEB member was needing support around specific SDOH needs, let's say, for example, they might need support with pest control and their child has asthma, or they might need support with paying their housing application to move into a better home for their family. Those are things that we would be able to use a flex fund for in order to support the members with day-to-day needs as it relates to SDOH. At the provider level, then, we would be working on how we start to integrate all of this into our provider portal with population health reporting so that providers can also access our SDOH programs and understand the health of their population that they're serving. We would also be aligning our value-based contracting. I talked about that a little bit before, around equity-based contracting and starting to move towards really incentivizing SDOH support as well as health equity outcomes in our provider space. And then we'll be executing our quality improvement work plans specific to SDOH and health equity within our providers. So this is about us going in, identifying providers, sitting down with them, process mapping with them, providing resources for them to be able to really move towards equity and providing SDOH support to OEB members. And then within the community, we're looking at piloting a community food program, which would include potentially working with one specific area that would be able to probably a non-urban area where they would be able to have resources to build out a community garden within a school and then support community education and access to the food from the community garden. Erica, I'm going to go ahead and pass it over to you, but I'm happy to take any questions. I know that was a ton of information.
Thank you so much, April. April just did a fantastic job of providing background information on the work that we've been doing, as well as exciting work that we have coming up. And she also gave a high-level overview of the programs that we're proposing. So I'm going to dive in just a little bit deeper into that section that April just went over on the member side. So the first thing I'm going to be talking about is that we're going to be proposing covering health-related services. And for people who might be a little bit more familiar with the CCOs and involved in the CCO world, maybe you've heard this term before. But health-related services are non-covered services under the plan that are intended to improve care delivery and overall member and community health and well-being. So coordinated care organizations, or CCOs, already are providing coverage for health-related services, and that includes our own EOCCO, or Eastern Oregon CCO, as well. And the Oregon Health Authority has really supported the CCOs in providing this coverage, and the OHA has even identified health-related services as the primary strategy by which CCOs can help address their members' SDOH needs. Yeah, I see a question, Robert.
Yeah, Erica, could you give an example of what a health-related service would be?
Yes, I'm actually going to dive down into that, into the different health-related services that we'll be proposing. So yes, I'll be getting there on the next slide, and on this slide. Thanks, Robert. Because so the CCOs provide, coverage for a lot of different health-related services, and we're going to be focusing on 3 of those services for the upcoming year. And as April mentioned, we are proposing to start small and pilot this with our type 2 diabetic members for this year. But MODA really does have plans to expand coverage for these services in future years, because we really do believe that by reducing barriers to accessing the healthcare system and reducing barriers in being able to manage a member's health will have a positive impact on additional populations as well. Yes, Tom. Oh, you're muted, Tom. Oh, okay. You want me to keep going?
Sorry, no. When I've heard about CCOs and providing health-related services, examples were like air conditioners, for people who are at risk. What percentage of the budget, of the total CCO budget, would fall into this category? Was it 1%, 5%? I know it's not 10%. And then as you go through your presentation, it would be helpful to get a sense of, again, what percentage of premium are you looking at putting into these categories?
Yes, thank you, Tom. And I will have more information on the percent of premium with the next meeting that we have. I won't have the percent of premium impacts with this presentation, but that is something that we're working on.
Yeah, I mean, it's one of the things that we need to hear as things move forward.
Yeah, thank you.
Thank you.
MODA's going to be proposed, or we are proposing to add coverage for 3 different health-related services for the upcoming plan year. And so those 3 categories would be food benefits, flex funds, and then expanding our coverage for interpretation services. So I'm going to go into details on each of these benefits. So the next slide, please, Rose. So first, we're going to talk about food benefits, and April has already done a good job of really describing how food really is medicine and how eating healthy can support members and their health, especially members with chronic conditions. And I think we all know, especially as we're coming out of the holiday season, it can be very difficult to eat nutritious foods, especially if there are barriers to being able to access healthy food. So there are a lot of different barriers to access. One example of a barrier to access is availability. So if there are not stores that are nearby that actually sell healthy food, then that can be an access to members actually being able to buying and using healthy foods for preparing meals. Another barrier to access could be transportation. Maybe somebody doesn't have reliable transportation. Maybe a store is 20, 30 miles away, but if they don't have reliable transportation to be able to get to that store, that can be a barrier to accessing healthy food. And another barrier can be financial barriers. We all know that eating healthy or buying healthy foods can oftentimes be more expensive than buying non-nutritious foods. So for members who have some financial difficulties, it can be hard to actually make that lifestyle change in preparing healthy foods for themselves and their families. So as April described, one of the benefits that we're proposing is a medically tailored meal program. So this will be initially focused on our type 2 diabetic members who have recently been discharged from the hospital. And we are proposing to send them freshly prepared meals right to their home. And this would be at no cost to the member. So next slide, Rose. I want to take you through just a little bit of a member experience, so how this would look for the member. So when members are discharged from the hospital, we receive that notification. So when we get that, then we will reach out to the members, and we'll have one of our Care 360 navigators reach out to the members. And as they're talking with that member, they will describe the food benefit that they have available to them. And at that time, the navigator can help get them set up on their initial meals, because we really want to get this started so that we can get the meals sent out to the member into their home. And the average time, it usually takes just a couple of days from when we first initiate that order to the food actually being delivered to the member's house. So the navigator will work with the member just to identify any preferences for food, allergies, or maybe things that they just don't like. We don't want to send them, if they don't like tomatoes, we don't want to send them tomatoes, because then they're not going to eat the healthy food. At that same time, the navigator can help the member get set up with a digital app. And when the member gets set up with that digital app, then they can actually go in and set their preferences and manage their food benefit themselves. So they can go in and they can identify any cultural or lifestyle preferences they might have for their foods. they can identify allergies, and preferences there. And the benefit will provide up to 2 weeks of meals that'll be delivered to the member's doorstep. And members, this will be delivered throughout the entire state of Oregon, even in the rural areas, as well as nationally. So the benefit will be available to members who live anywhere in the country. And after the navigator works with that member, they're not just done. That member is now involved in our Care 360 program, and the navigator will be, checking in with the member to ensure that they're doing all right and see if they have any questions with their food benefit. So any questions about that medically tailored meal program? This one is really meant to be more of an, meeting more of an acute need. So when members are being discharged, and I'm going to go into our food as medicine program, which is really going to be looking at more of a long-term support. So any questions before I move on?
This is Tom. The question that I have is whether or not whether or not this type of program has been piloted before, whether or not there's kind of some science behind it, or you guys on the leading edge.
Yeah, I'm going to start this and then I'm going to pass this over to April. We currently have not rolled this program out to anybody on our MOTA plans. This would be brand new, and we'll be using learnings from our EOCCO to implement it for OEB. But April, can you better answer that question?
Yeah, and I'm actually one of the reasons why I'm so excited about this program is there is a really strong scientific base for really food as medicine and medically tailored meals. And we actually put some information together, happy to send it over to you guys, that shows a lot of national research, academic research that's been done that actually shows what the return on investment is for this type of a program. When we talk about type 2 diabetic members, we're piloting it with that population specifically because we know that there's a really strong ROI with that population when we're talking about a medically tailored meal and a food as medicine program. And so we're starting out within MOTA, where we know there's an abundance of literature that supports that we should see a really strong return, not just on the member's quality of life, but also on reduction of things such as inpatient admission, length of stay, as well as emergency room reduction. So really, when you really break it down, and this is why I'm just so excited about it, it not only will save our health system money, it'll save OEB money, but it will also make our members healthier. So it's a win-win when we're thinking about it from a strategy perspective.
That's great. Jeff, you're on.
Yeah, how is the cost of this program passed on? Is it a claim cost, or is it outside the plan, or just from a general accounting standpoint?
Yeah, Jeff, that's a good question. And it will be a claims cost that'll come through on the claims bill.
So because it has a claim impact, I think I'd like to see the more formal ROI presented.
Yeah, we are currently pulling.
Sounds great, but I just due diligence.
Those are the important details, Jeff and Tom, and we are working on pulling together those costs because we are going to be utilizing a vendor for this program as well. And we are also pulling together the ROI because we do believe that there are savings associated with the program. Yes, Jeff.
I'm just trying to figure out how to take my hand down.
Oh.
Yeah. So the other question is, again, speaks to the issue of of health equity. Is the idea that this would be available to everyone who's post-hospital type 2 diabetes, or would it be to populations who are at risk? I can imagine, someone who is who would really needs the help, the service, and others that it would not, that they can afford this. And I wonder whether or not that's already embedded in that first step. The Care 360 will contact members. Actually, it would be the first two, whether or not again, if I was in this situation, I look and say, would I need that type of help, or could that's something that I could manage, versus someone who couldn't afford or couldn't obtain the healthy food.
Yes, thanks. And I'm actually going to pass this over to April
Okay.
to respond to.
Thanks, Erica. So there's a lot of options for how we might want to slice this, but really when you look at the literature on it, what the literature shows is that, especially when we're talking about medically tailored meal programs, when someone is discharged home, even if they have the means to obtain healthy food, we're talking about type 2 diabetics, it often goes back to, and Gail, please jump in here from a clinical perspective, but it often goes back to really behavior change, goes back to things associated with diet and weight. And so even if someone may have the means, there hasn't been a behavioral shift where they're actually really able to control their diabetes through a healthy food program. And so what the literature really shows is that by supporting them, especially when you're coming home from the hospital, you're already less likely to be able to easily prepare food because you're sick, right? You were just inpatient. You may not be able to get to the supermarket and purchase what you're needing, or even really have the wherewithal to plan out, diabetic tailored meals over the next 1 to 2 weeks. So this type of program will basically take that stress off of the member and start them on a journey where they're able then to have diabetically tailored meals delivered to them so they can start on that behavior change. And then we'll start working with them long term through the Food as Medicine program to really support a much longer term behavior change. Some of the research studies, awesome.
That's good. Yeah, I get what you're saying. I appreciate that.
No problem.
So it's a program for all, and that's
it's a program for all. But however, saying that, when we're talking about the Food as Medicine program, there is the opportunity to really tailor that to members that have identified SEOW needs. And I've seen research on both, and both have strong outcomes, but we're open to looking at how we might want to do that in a way that's going to work best with OEB. Our recommendation is going to be to pilot it with all, and actually to do an academic study, which we've already started talking about within MODA, and maybe even do that in partnership with OEB to show how this applies to the commercial population and how it does reduce utilization and ED spend, so we can scale the program long term. We're trying to do it in a way where the population is small enough so the cost impact won't be very large, so we can show the success and then scale it from there.
Super.
Thank you, April. And that actually takes us right into the next slide, Rose, if you'll move forward. April talked about how that medically tailored meals are really focused on that acute need, but then transitioning members into the longer term behavioral change, which is our Food as Medicine program. And so through this program, members will receive produce and pantry boxes that are also delivered right to their door. The food deliveries are culturally and lifestyle relevant and sourced from local farms and suppliers when available. Obviously, there are different times of the year that local produce is more abundant than in other times of the year. And as April also mentioned a little while ago, the box will include food for up to a family of 4. And April already mentioned this, so we'll just briefly hit on it. If we're only sending food to the target member, but everybody else in the household is preparing something different for dinner, then that could be it could be more difficult for that target member to actually sustain the behavioral change that we're really aiming for. Through the program, members will also have access to the digital app, and that app provides personalized support for the member, and then they can use that app to customize their nutrition box. Again, if they don't like tomatoes, we don't want to send them tomatoes because they're not going to use that to prepare their meals. Then they can really control the boxes that are being sent to them through that. The app also will support members by providing them recipes to be able to use the food that they get to actually prepare the healthy meals. Because if you get a box and it contains a bunch of food that you're not used to preparing meals with, it can be very overwhelming. I know I would be very overwhelmed with a box full of food that I don't have any experience using. So the recipes are really there to help support members in being able to use that food to cook that meal. And the app is there to help support them in learning how to even shop for that produce. So we start with giving them the food and teaching them how to use that food to prepare meals. And then it's really more of a long-term behavioral change where then we shift into helping support members and teach members on how to shop for that food so that they can create the healthy meals for their family. The program is intended to be more long-term, so really looking at more of a 6-month program to really implement that behavior change. Yes, Robert.
Thanks, Erica. Is this program part of the food is medicine program, part of the medically tailored meal program? And is it the same target group?
It is the same target group, and the answer to that is yes and no. So we will be transitioning members who might start in that acute phase into the food is medicine program, but the food is medicine program is also available to others outside of that, but it is targeted initially at that type 2 diabetic population. And April, I don't know if you have anything else to add to that.
Just one caveat to it. So the food is medicine program, the difference is it's not going to be targeted only to members that had a recent inpatient stay. It's going to be targeted to type 2 diabetics that have uncontrolled HbA1c levels. So we're still toying around with what that level will be. We're hoping for a 7.5 or above, which research really supports, but we're wanting to ensure that our data that we're able to obtain will match that based on how HEDIS is reported. So don't want to get into the weeds, but basically it'll be uncontrolled diabetics that are type 2, whereas the medically tailored meal program will be those that also had an inpatient stay, and then they can transition over to this. If they had an inpatient stay, most likely they're also uncontrolled.
So obviously a lot more details about the program over time in terms of budget and all of that, but definitely we're hearing the what's behind the theory behind it, the potential rollout, the potential populations, and it's very again very innovative, and we'll see how it works.
Great, thank you, Tom. All right, so any other questions about the food program before I move on to Flex Funds? Great, next slide, please, Rose.
And Erica, you have 25 more minutes total.
Perfect, we can do that. So the next program that we're proposing is to cover Flex Funds. So members can experience barriers to being able to access the healthcare system or to manage their health. And one way that we just described was through food. However, members can also experience other barriers to accessing the healthcare system or managing their health, and each of those barriers can be unique to them. So we're proposing to provide Flex Funds that can be accessed through our SDOH Care 360 team to provide coverage for services to help members remove those barriers, even for services that are not covered by the plan today. The CCOs, including our own EOCCO, cover this benefit, and we're modeling our program off of the EOCCO program, but really tailoring it to fit the OEB population. And so I want to give just a few examples of what this might look like, because I think that'll probably be the best way to help describe the program at a high level. So one example is transportation to an appointment. So that can be something that the Flex Funds cover. And an example of this, we have MODA 360 advocates at MODA, and one of their jobs is to reach out to some of our higher risk members and help them with all sorts of things. But one thing that they help members with is in closing gaps in care. So I was talking to a couple of our advocates, and they were saying that oftentimes they will help members who maybe need a preventive exam like a colonoscopy. So they'll help the members find the provider. They even help the members schedule the appointment for the procedure. But they said that a lot of times, more than half of the time, those members actually end up canceling their appointment. And when I heard that, I was just really shocked, because I felt like, well, a big part of that is done, when you get the appointment scheduled. And I just asked, well, why is that happening? Do you know? And they said with some procedures, especially colonoscopy, they have medication that's given during the appointment. So a member has to have a care person with them or reliable transportation in order to have the procedure done. So you can't just drive yourself home after that procedure, and you can't take an Uber or Lyft. So if a member doesn't have a care person or a way to get home, then they have to cancel the appointment because they can't have the procedure done. So I asked the advocate, I said, so if they had, access to medical transportation, then could they have the appointment? And the answer is yes. And so that's just an example of a way that we can use these funds to help our members access the healthcare system and access the preventive exams that they need. Other examples, and Tom, I'm glad you brought this up because I know we've all heard about the air conditioner example. Dr. Kitzhaber really used this when he was sharing his vision of the CCOs back in the beginning. But I still think it's a very relevant example. And if you think about a member who has chronic conditions or a chronic condition, and let's say they live, in a place, maybe an apartment building on the second or third floor, and they don't have an air conditioner. Well, we know that parts of Oregon in the summer can get very hot. It feels like maybe they're getting hotter in recent years. And when a member doesn't have an air conditioner, it can really exacerbate their condition, which can lead them to needing to end up in the ED or seeing their provider in the hospital. So by providing something as simple as an air conditioner, it can help the member really manage their health and chronic conditions better. The flex funds can also be used to provide items that improve mobility. So members who may have limited mobility, by helping them be able to access and move around a little bit more, it can actually help them manage their chronic conditions better as well. And one thing I like to point out with these flex funds is the purpose of them. So the purpose of the funds is to support members with an SEOH need and help them establish a permanent plan to meet that need. So the intention is not for these funds to be the permanent solution, but rather it's intended to be the bridge to a permanent solution. There are a lot of resources that are available in the community to be able to help members, but sometimes it can take time in order to be able to find and connect with those resources. So these funds are really aimed at being that bridge to helping members get to a more long-term solution. And that's really the way that the CCOs are providing this benefit today to their members. So our initial proposal focused on our type 2 diabetes. Again, we want to start small with this and look to expand it later. So we'll be looking to roll out these flex funds for that type 2 diabetic population as well. And we're proposing for the initial year to allow up to a $200,000 annual maximum or cap on those funds that our SDOH team can use. And again, more details underneath that with the next round. Any questions or comments on the flex funds?
Sounds great.
Great. Anything else to add, April? Well, then I'll go to our third health-related service. We are proposing to expand our language services. So today, MODA provides coverage for translation and interpreter services when a member interacts with us. So for example, if a member reaches out to a health navigator and let's say they speak Russian, we will bring a translator on who speaks Russian so that we can have a conversation and communicate with that member. We also provide a lot of our documents, or our documents are all available in other languages. If we don't already have that document translated into the language that the member needs, then we will have that document translated for them. However, when a member interacts with the healthcare system, so when they're with their provider, we don't cover an interpreter at that point. So for example, if a member speaks Spanish and they go to their provider's office and nobody at that provider's office speaks Spanish, then that member has a barrier to accessing care because they can't communicate effectively with their provider. So we are proposing to expand our coverage to cover interpreter services for members at the provider's offices. This is something that the CCOs cover today. So we will be looking to utilize the relationships that we have with vendors that our EOCCO is using and to expand these services to the OEP members. The way it's used today, it covers both in-person and virtual interpreter services. So for example, a provider can ask for an actual, we'll do a request for an interpreter, and that may mean that an actual person will be there in the office doing the translation, but it can also mean a virtual interpretation. So providers' offices might have an iPad, and then they log into the interpretation service there, and that interpretation is done virtually. And that can be helpful when you're thinking about access issues, or if you're thinking about providers' offices in maybe more remote areas of the state where it can be more difficult or challenging to get an actual person there. And that's the way the CCOs utilize that service today. Any question about that?
I understand what you just said. Does your contracts with your providers require that they provide interpreter services?
I do not believe so, no.
Okay, I'm very surprised by that because I've been operating with the idea that a interpretation of our conversations around language services, that already was in place.
Yeah, and I will confirm that, but Tom, I do not believe so.
Okay.
And maybe I can add to that. I can't speak directly to what's in our provider contracts, Tom, but in relation to what you're talking about, as you probably know, it is federal law that providers, right at the point of service, need to be able to have access, or they need to be able to provide. A member basically needs equal access. So they need to be able to have access to language services that will support them in their health care journey at any point of contact, hospitals, clinics, health plans, right?
Okay.
And so a lot of times how
so it's covered through that direction. Okay.
Exactly.
Okay.
So often,
because I thought it was. I just
it is legally.
Okay.
But a lot of providers don't, or they'll use a minor, or they'll use someone that can, even though there's laws recently against that with the ACA, it's just a really significant barrier. So if there's one general point of delivery for language services, it eases the burden on providers, which improves the ability for them to access it, which means that members will get a higher quality service by doing something like this.
Yeah. Jeff, question?
So this service is in addition to what's the providers being reimbursed. Is that correct? In other words, the provider doesn't have to absorb the cost of this?
That's correct.
Okay, because in the past, one of the unintended consequences is that a provider would be required to provide a translator, and the translator would cost them what the negotiated rate was, and they're going, why do I want to treat people where I lose money or don't make anything? And so it needs to be an integrated approach.
Correct, Jeff, and that's a good point. And yes, this would be through the vendor, so the provider would not be, it would be us covering the charge of the provider using the vendor. And I do know that, some providers today already use translator services. Some of them might, because they do that to serve their members. But as April pointed out, it is not something that every provider does.
Yeah, we don't want to solve one problem and create an access problem.
Correct. Yes.
Yeah. Okay.
All right, next slide. So I'm going to pass this over to Dr. Popowich for really quick to talk about a program that we feel complements the food programs that we've been rolling out. Dr. Popowich?
Okay, thanks, Erica, and thank you, Karis and April, and Happy New Year to all of you. So all of what we've been discussing, and particularly the Food as Medicine program, to me is very near and dear to my heart. I truly believe that one of the inherent problems with our healthcare system is that we approach disease conditions as individual entities without looking at sort of the whole patient as how we can improve things. And there's no better way to do that than with healthy food. And with our type 2 diabetics, as you know, we've been taking our diabetes approach in many different ways. We've approached it from our pre-D program to try to preempt and prevent people from becoming actual type 2 diabetics. And then we also have implemented with great success Livongo for our patients who are diabetic. But Virta is a vendor I am sure many of you are already familiar with, but it is a pretty amazing program that is their goal is to reverse type 2 diabetes as best they can. Is it going to completely eradicate it in every patient? Absolutely not. But what they offer is a program that will help lower blood sugar, reduce medications, and ultimately lose weight. It's a physician-guided program, app-based through the app or through your computer. They provide all of the diabetic supplies like Livongo does with a glucometer, a connected glucometer to the app, as well as a connected scale. And an MD is monitoring everything that's happening. They will review current medications that a type 2 diabetic is coming into the program with. They will send that member to a lab to get a baseline A1C level, or they can just base it off of claims data and then help set goals for that member. They do, and we'll go into a lot more detail about Virta again at our next meeting. But they They put their fees at risk. They will reduce A1C by at least 1/1.3 points. They will reduce insulin, and this is another fee at risk. They will reduce insulin requirements by up to 94% of patients who enroll in the program. And they'll also decrease medications, which by reducing just insulin alone, the cost savings right there are pretty tremendous. So we plan to offer this through Moda 360. It has tremendous synergy with our food benefit and this Food is Medicine program to help support members in this journey to get access to fresh produce, meat, fish, and poultry, which can be a barrier for some. And we feel that this program, the Food is Medicine program, will really help members get on the right pathway to eating better. And Virta will help with that as well. They want, that's something that I've talked to them about, like how do you handle, your lower income patients? And they have solutions that menu plans, diet plans, and some say it's strictly a keto program, and it's really not strictly keto. Keto is part of it, but it's much, much more than that. And very excited to add this sort of final piece into our approach to our diabetic patients. So that's all I'll say about it for now. I'm happy to answer any questions about Virta, but more to come for sure.
Is anybody in Oregon using it now? Do you know?
They are.
Yes.
I believe Providence is using it with PEB, I believe.
Yeah,
Yeah.
this is Margaret. That's correct. We did start Virta with the PEB group with Providence just this year. So still early and expect to have some data on sort of initial experience relatively soon here.
Great.
Do you, Margaret, do you have any early just member satisfaction information, or is it still just all too new?
It's still all too new. I think one thing to think about, and one thing I'm curious about, and I don't know, Dr. Popowich, if you have any thoughts to share now, but in terms of, so Virta, when you sort of look at the population level statistics, there's potentially a lot of people who could be eligible for the program. So I'm wondering if and it may be a little bit early in your planning, but have you given thought to sort of like targeting and recruitment and how you plan to sort of identify, will there be like a sort of a member opt-in, self-identification, or sort of how will all of that work? Because I think there are members out there who could certainly benefit from this who don't even really realize it's a thing that they could benefit from. So just wondering if you have any thoughts on that at this point.
Yeah, and Erica may have more data about this than me, but I would say the one thing I do know about Virta is they have an extremely high retention rate. Any lifestyle modification program, whether whatever it may be, is always going to come down to patient motivation. Like, if a patient is not motivated to want to change their diet and lifestyle, they're not going to do it. Virta maintains an 83% retention of patients after a full year, which is pretty remarkable, considering it is a program that does require you to change your lifestyle in a pretty dramatic way. But they're very supportive in how they do that. The app, they reach out to you, they text you, they really are very, very hands-on with the patients. In terms of the rollout, maybe Erica, do you want to talk about that a little bit? Yeah, and how we would like to make this available.
Yeah, so Margaret, that's a great question. And it's a question that we are beginning to talk about. So we will be targeting the members that we invite into the program. We will not be doing it where we put it out, where we won't be sending out a mass email to the entire OEB population, inviting them into the program. We will be looking at our data similar to the way we've been doing within the entire Moda 360 platform, where we look at what programs are right or best for what members, and then targeting those members with the programs. So it will not be a huge, wide rollout of the Virta program, at least initially, not at first.
Right. We don't want to just dive in head first. I think targeting the most at need for this program would be the best way to start, and then we can always ramp it up as the years go.
Yeah, great. Thank you. That's helpful. Thanks.
Erica, you've got 10 more minutes.
Okay. April, did you have something to add?
Yeah, just real quick, I was going to add that the way we're looking at designing this is that the Virta component will be the same population that's eligible for the Food is Medicine program. And so we'll really be tailoring this to the population that meets those parameters of our uncontrolled type 2 diabetics but looking at it from a pilot perspective at around, I mean, we're still working on the numbers, but probably around 200 members initially for the pilot phase. Then we'll be doing the evaluation, showing the ROI, and then hoping to scale that in 2024.
Thanks. All right, in
Great.
10 minutes,
Thank you.
I can do, Tom.
I know you can.
Two more slides, Rose. All right, so I just have one more program or change to discuss today, and it is on dental. And it is preventive services for children. So most of you probably don't know, but I am going to take a second just to talk about this. But MODA actually has a long history of providing dental care for children. And actually the ODS companies, or the Organ Dental Services companies, were actually founded on this when the International Longshoresmen Union were looking for a way to provide affordable dental care for the children of its members. So we got our start in really looking at providing dental care for children. And I also just want to highlight that OEB has really partnered with us through the years in promoting preventive utilization on our dental plans through innovative benefit design. And as Mercer and Willis Towers Watson have shown, the Delta dental plans have pretty high preventive utilization on our plans. And so a change that OEB just added for this current plan year that I'm so excited about is the Preventive First program. And I love this program because it allows members to be able to access more preventive services. And it does this by making preventive services not subject to the annual benefit maximum. And those charges don't accrue towards the annual benefit maximum. So if members have, maybe they have a year where they have, an implant or root canals, and they are really using that, the majority of that annual benefit maximum, they can still get their preventive services because those costs are not subject to that benefit maximum. So a really great enhancement that we've made to our plans for this year. And the majority or several of our OEB plans provide preventive coverage at 100% today. So plans, the exclusive PPO plans and Plan 6 cover preventive services at 100%. So members don't pay anything for those costs, especially now that we've added the Preventive First program. However, plans 1 and 5 can still have member costs for preventive services. So plans 1 and 5, which have quite a few members in them, they have an incentive level benefit on preventive services. So that means for the first year members in a plan, preventive services will be covered at 70%. If the member goes in for a preventive appointment during that plan year, then the next year their benefit goes up to 80%. And it'll go up that way until it reaches 100%. And then at that point, then preventive services are covered at 100%. But until they get up there, they're still paying out of pocket for prevention. So Delta Dental is proposing to cover preventive services at 100% for children on all of our dental plans. So that would mean for plans 1 and 5, for members under the age of 18, we would cover preventive services in full. And we believe that this is one more step forward towards removing barriers to children being able to access the important preventive services. Any questions? That's our dental change. Any questions on that?
Obviously, we'll be hearing the cost implications of that over time.
Yep, that'll be presented with the next. Yes.
Okay. I like it.
Perfect. Yeah, I do too. One more step in helping increase preventive utilization for members and really removing barriers to being able to access prevention.
Yeah.
And I just want to say thank you, everybody, for allowing us to talk today. We're really excited about the program changes that we've been working on and really looking forward to another renewal. So thank you.
Okay. All right. Thank you. We are going to stop now, and I have it at 11:17, and I'd like to start again at 11:25. So I'm proposing a 8-minute get up, walk around, bio break, whatever, and we'll restart at 11:25. Okay? All right.
Sounds good. I put that in the chat, Tom. So
Good.
see you in a few minutes. You bet.
Okay. Bye. Rose, I have a question for you. Are you there yet, Rose?
I am here.
Do we have any public comment?
No.
Okay. I'll try to remember to ask that at the final bit when at the end of the agenda.
Oh, I don't think we'll have any. We rarely have public comment for SEOW.
I know we've had it. I think the only time we've had it has been around the benefit request, but
yeah,
maybe that went to the full board. I don't remember.
Yeah.
Okay.
They usually want to comment at the full board, not at SEOW.
Right. Right. Okay. Thank you. Okay, my computer tells me it's 11:25, so I am calling us back into session. And what we have is, and as Rose has on your screens, the 23-24 VSP proposed plan design changes. So away we go.
Good morning, everybody. And oh, well, yes, it's still morning.
Still morning.
So I'm Valerie Swires. I'm the market director that works with you directly on OEB. And I'd like to say Happy New Year to everybody. And I hope that 2023 is a great year. So I'm going to take a few minutes and we're going to look at the current plan design offering, going to talk a little bit about utilization. That's been running very well. And then going to look at some of the proposed plan changes, looking at two, matching the retail frame allowance of $150 and $300 at Walmart, as well as adding retinal screening covered with a $10 copay. And then we can go over any questions or follow-up. So next slide, please. So OEB has been with VSP since 2017. And while we look at the renewal annually, we did set a 4-year rate guarantee that is in place through October of 2025. But that doesn't mean that we don't look at how the plan is running and what are some changes that can be made on an annual basis. Next slide, please. So currently there are 2 plans that are being offered. It's 2 out of 6 of the total all overall vision benefits that are available to OEB members. You have the Choice Plan and you have the Choice Plus plan. Both of them are on an annual benefit frequency of 12, 12, 12, and that's for exam, lenses, and frames. Currently, It's on a service year. So if you get your exam, say in January, then you're next eligible next January. Or if you were to get your frames in February, then you're next eligible in February. So 12 months from when you last received your services. One of the changes that I am going to propose, very slight, and that is that we refresh benefits as of the count or the plan year, which would be October. There would be no impact to make this change. I believe that you have several other benefits that refresh at that benefit plan year versus on the service year. And that would be something that would be very valuable for those members who maybe, don't remember and every, 12 months from when they last received services. And I'll offer a lot more flexibility for their plan offering. Copays, both plans have a $10 copay for the exam and a $20 copay for the materials. The key differences are in the frame allowance. The choice plan is $150 and the choice plus plan is $300. So pretty big difference between those offerings. And the same with contact lenses, $150 for the choice plan and $300 for the choice plus plan. And then when you look at lens options, lens enhancements, again, here are some differences between the two plans. Standard progressives are covered for both. Scratch resistant coating is covered for both. Protection and polycarbonate lenses for children. The Plus plan has polycarbonate lenses for adults. This is a higher resistance to shattering and breaking. It's also a lighter lens, and so very popular, something that we put in place many years ago for children because we didn't want adults not selecting polycarbonate lenses for their kids because they were going to have to pay a little bit more for it. So that's something that all of our plans cover, and it comes out of our general fund. And then premium and custom progressives with a $15 copay are covered in full, as well as anti-glare coating is also covered in full with a $15 copay for the Plus plan. Essential medical eye care is provided for both, and this provides additional services for diabetics, as well as people with macular degeneration and glaucoma, and then also for conditions such as pink eye or, an injury to the eye. But this is secondary. Medical coverage is primary for medically related eye conditions. The contact lens exam is covered in full with a not to exceed $60 copay. They also, for both the choice plan and the choice plus plan, get an extra $50 to spend on featured frame brands. So this gives them additional monies towards frames such as Nike, Calvin Klein, Columbia, just to name a few. We have quite a few that are on this list. And then Light Care. So Light Care allows members who don't need a prescription to use their frame allowance towards ready-made non-prescription sunglasses or blue light blocking glasses. This is instead of prescription glasses or contacts. And then vision therapy. This was something that we added just a couple of years ago. It's fully covered evaluation up to 75% of the approved therapy sessions, not to exceed $750 annually. So I'll go ahead and have you go to the next slide. So in some of the enrollment, when we were implemented back in 2017, we were added to your already existing offering of vision benefits. And over the years, you can see here, we're having a nice increase in enrollment. And so in 2020, we had a 18% increase in enrollment over 2019. In 2021, we had a 4% increase, and in 2022, 12%, and most currently, as of this October, we had an 8% increase. So we have a little over 14,800 enrolled in the plan. Total overall, I believe enrollment in your vision benefits is close to 50,000. So you can see, we keep growing, we keep increasing enrollment, and we believe that that will continue to happen, especially as we continue to make improvements to the benefit offering, as well as that our costs are very well controlled. Next slide, please. At those historical plan trends. So that average claim cost, very, very stable. You can see here, 2019 to 20, we saw a slight increase and then staying pretty stable in 2021, and then a little bit of a decrease, but again, very, very stable in 2022. And this is because we are cost control and negotiating discounts less than usual retail and customary with our provider network. Next slide, please. So when we look at kind of like that rate of utilization or that paid frequency, we looked at this year over year, 2019 through 2022 plan year. And you can see we had this dip in 2020 when a lot of our practices closed, just like everybody else. But historically, we don't see a lot of fluctuation in that paid frequency. We're not quite yet back to the paid frequency of 2019. So right now, or for 2022, our paid frequency was 117 claims per month per 1,000 members. And in 2019, it was 127 claims per month per 1,000 members. So we believe there is some room here for our paid frequency to go back to what it was historically. So these are things that we take into consideration before we make any large changes at renewals or rates, because we know that we could see some huge increases in enrollment. We could also see some large increases in utilization as far as the number of claims if everybody, starts going back and really going and utilizing the plan as they had prior to COVID. And we do expect that. Next slide, please. I want to apologize for a typo here. Right here it says 2021. These numbers are actually for 2022. I have 2021 over here on the right, and then 19 as well as 18. So as I mentioned, one of the things that I am going to be proposing, and it is a change that we made to PEB's plan designs for 1/1/2023, and that was to match the frame allowance of 150 and 300 at Walmart. Currently, they are at $80 and $165. And one of the reasons, and the impact to this is very, very low. It's only 1%, so very small, and it will increase the perceived financial equity for members that predominantly choose to obtain services at a lower cost retail provider. And since Walmart is often in rural areas, this is considered to be, in areas where maybe it's a healthcare desert. It increases equitability by geographic location as well. And you can see currently and in years past, these two allowances are covering a large percentages of the frames that are being selected. The 150, this equates to $57 on the wholesale, which is how we reimburse, including some dispensing fees. And for the wholesale on the 300, it's $115. We know that at Walmart, predominantly the percentages of frames that are available are in the lower cost range. That 150 retail is going to cover about 97% of the frames that Walmart offers. And so that's really going to expand the coverage. But again, the impact is very low, 1%, because the majority of frames that are going to be available are not within that 150 or even that 300. It's just that it's a perceived equitability from a financial perspective. And then on the $300 frame allowance, you can see here 88% of frames that were selected in the plan year 2022, 88% were covered in full. So the average out of pocket was only $9. This is across, all of the claims. So very, very low out of pocket costs. It's also one of the reasons why this is the plan that is most selected by members, looking at the two plans between the Choice and the Choice Plus plan. Next slide, please. Might be a little bit early, but I did include slides that kind of outlined the impacts to the changes that I was recommending. So for the Choice plan, your fully insured rates, for tier, looking at increasing that match to 150 for the Walmart frame allowance, 1% or 2 cents, very low per employee per month. And then I'm also going to be suggesting adding retinal screening with a $10 copay. This does have a little bit more of an impact. It's a flat cost that's going to be added. And I don't want you to be scared by that 7.3%. That's only equating to $1.57. So very low, and as well as I am going to be extending a discount to your current rates. So we will not have to be concerned about that cap of 3.4% increase. All right, next slide, please. And then the Choice Plus plan. Again, only that 1% to match the $300 frame allowance at Walmart, and then adding the retinal screening with a $10 copay, a 3.9% impact, or $1.90. And again, going to be extending a overall rate decrease, so do not need to worry about that 3.4% cap. Next slide. Thank you. I'm going to go into a little bit about that retinal screening. So when you think about a well vision exam, there are 4 components that are included. There's that patient health history. So that's that conversation that you're having with your provider. You have some preliminary testing, looking at things for your visual acuity, different things like that, refraction, and then ocular health assessment. And looks like we went over to the next slide, so that's just perfect. And that retinal screening is really a piece, it's a component that that I'm recommending that is in addition to what is currently offered in the plan design. So While dilation of the eyes is still recommended as standard of care for viewing the retinal nerve as well as the blood vessels of the eye, many people are very sensitive to dilation, and recovery times can be several hours. As a result, it makes it harder for some people to schedule an appointment, limiting them to only times when they don't need to return to work or have anything else to do, or possibly just on weekends. So members may even choose to put off dilation 1 or maybe even more years, and this reduces the chances of detecting conditions that impact your health, such as diabetes, diabetic retinopathy, hypertension, high cholesterol, and as well as these conditions could impact your sight. So retinal tears or retinal detachment, if they're not caught early. So while we cost control the retinal screening with a not to exceed $39 copay, this may still limit access to some members with lower percentages of household incomes, or maybe they have multiple children. And so paying that additional $39 could impact their ability to receive those services. I'm sorry, I did not miss that I missed that your hand was up. Please go ahead, ask your question.
Go ahead, Jeff. I'm not hearing you.
Yeah, I was on mute. So my question is actually towards our 2 health plans, because I'm under the impression that retinal screening is covered under our medical plans. Is that true or not?
Jeff, this is Sapari with Kaiser Permanente. Yes, I believe that is the case, but I would like just to confirm.
It's possible the complexity here, retinal screening, when there is a reason for it, I'm sure is covered. So if you have diabetes, I'm sure retinal screening is covered. The issue, and I think what's being offered here, is that this would be a general screening for the population who don't have a specific indication. They're coming in for an eye exam, and they are being given this retinal screening even though they don't have indications or concerns of glaucoma or macular degeneration or diabetes or a retinal tear. So
that is correct.
That's okay. So the medical covers whenever it's indicated. What we're going to need to do in the interim is figure out whether, what people have, what they recommend for retinal screening, because I'm sure it's been studied. There's no question for disease conditions that it has been shown to be an appropriate treatment. For the general population, I do not know whether or not retinal screening, there's evidence to support its use.
Tom, this is Erica, just confirming that on the MODA plans, it's covered for diabetics.
Yeah, well, and it's also going to be covered if someone has a history of macular degeneration or retinal injury and things like. I'm sure it's covered for all of those things.
So I think we should be considering it, but I think we need to make sure we've defined the entire picture here amongst our providers.
I agree. So we'll ask our 2 medical carriers to clarify when retinal screening is covered, and we will do a review to see whether or not what the U.S. Preventive Services Task Force says about retinal screening in the general population. There's another question that's coming from, it says DOCT RCI, Birch Creek Teams Conference Room 27. You're on.
Good morning. It's Greg Klauser from the PEP board.
Hi,
I'm
Greg.
at work, so when I'm at work,
I love
usually I
it.
use this room. It's a little easier for me than trying to find another computer.
I love it. Okay, great.
I would like to shed a little light from the PEP board as to why we did this. And one of the reasons is, yes, specifically myself, for the last 8 or 9 years, I have had this retinal screening done as just a normal person. I pay my $40 every time I go in to get it done. 2 years ago, they caught a health issue that we looked into, and it was caught earlier than it ever would have been. And so for me, I was able to then see my regular doctor, take a look at it, and I no longer have that. So I didn't use my medical plan. I used my medical plan, but I didn't have to use additional dollars in my medical plan for something that was caught early. And so, as you said, yes, there are many things that can be caught. We looked at this as something that we are hoping, for the minimal amount of cost to the plan, that those types of things will hopefully be caught in our people to prevent heavier costs down the road, if I may. And I've paid my $40 every year. I'm excited now that I get to pay $10 instead of the 40, and still get that same benefit. So from us, that's kind of one of the reasons we did. We're hoping, and as well, going to get some information on, this coming year, how that looks. But yeah, as a general person on the insurance plan, this has not been covered. Only if you have certain diabetes.
Right, you have to have the medical. Yeah, you have to have the indication. You have to have the
exactly
for the test to be covered.
Just a little extra there.
Yeah. Okay. Very, very helpful to hear how PEB added it and the rationale behind it, and our process through SEOW is that if we're going to add particularly I think this would fall into a prevention category. It's a screening. And so what's interesting is that if the U.S. Preventive Services Task Force had made it an A or a B, it would already be on the list of a required benefit at no cost. So we're going to need to do, it will be important for us to answer the question of whether or not there's evidence to support its use in the general population. And we'll be able to get that answer before we go on, and where the full board will be looking at adding benefits. So I really appreciate.
Right, and as a preventative, what we were looking at is that $40 plus the $10 sometimes because it's always asked when I go to get my eyes, do you want this or not? And so it's something that extra $40, I know that we chatted about, it may stop individuals from getting this screening, which then may help save us dollars in the long run. And so a $10 copay we felt was a little easier for our members to pay to maybe help find those items down the road.
Yeah, I get that, and Greg, I think it's my only, if it actually has, if the intervention, if the screening test has been shown to be of value from a population-based standpoint, it should be covered at no cost, just like mammograms and colorectal cancer screening and things like that. So our process is to make sure to look at the evidence around whether or not it is proven, the intervention is proven to make a difference from a population standpoint, as compared to not looking at the the again, if this made a difference, it should be not even at a $10 copay. If it's a prevention services that has been viewed as being one, cost efficient and making and identifying disease and reducing health burdens, should be covered at 0 copay, just like all the other prevention services that we have our providers pay for. So we'll do some additional research in this, and we'll get it done by the February board meeting, so we're able to give a report based on the science behind retinal screening.
So Tom, I don't know if it would help you, but I'd like to just reiterate. So the Board of Ophthalmology, the ADA Board of Ophthalmology, they highly promote retinal screening. However, it is not a replacement for dilation of the eyes. They feel that it is a great way to potentially diagnose and detect conditions early.
Yeah.
Because a lot of people are not getting their eyes dilated because of the sensitivity to dilation.
I
Number.
I know. I understand what you're saying, and I'm just trying to tell you how SEOW is structured and how it works, and an academy, the American, the ophthalmologists have a lot of entities have what they view as very important, and they aren't always backed by. We're just going to spend a month. We'll look and see whether or not the people who look at the science of population-based care recommend this or not. That's a simple. It's a simple statement, and I'm not trying to be. I'm just trying to hold SEOW to the process that we follow, which is built into our name. We look at the evidence and outcomes of recommended services. So that's what we're here about, and I appreciate what you're saying. I also appreciate what Greg says, but again, we are tasked specifically to look for evidence around whether or not interventions make a difference. So Robert, you're on.
I completely.
Yeah, thanks. Just to back that up a little bit, Tom, I went in for an eye exam about 3 weeks ago, and the retinal exam was pitched as a full alternative to the dilation. And as a consumer, I just said, sure, why not? Mainly because I could afford the $40 without the irritation.
Yeah.
So what I'd like to see is what is the efficacy of the retinal scan as compared to the dilation before we make that decision on whether to lower the cost point, because then more people will do just what I did. And if it's not as good if it's not a true replacement, then that's something we need to consider.
Yeah, exactly. So we will, this is a very important, I appreciate you raising this. The SEOW will essentially table this part of the recommendation for us to be able to explore we will not give a recommendation to the board on this additional recommendation until we've been able to look at it, and we'll discuss it in February. So Valerie, if you can be available, either Glenn or Margaret will outreach to you, and we will go ahead and work with our consultants and our and the OEB and PEB staff and come up with a further discussion on this.
Sounds good.
Okay, great. Any, I see that you're at the last screen. So if you have any closing comments.
No, I think I'm finished. If there were any other questions before we adjourn?
Anything else from anybody? Rose, do we have any public comment?
No, we have no public comment.
Okay, well, thank you. So thank you very much again, Valerie, and for both for the Kaiser Permanente and the MODA staff for your presentations today. Will be particularly some of the MODA plans or recommendations we heard in a way the first reading, and there's more data information about costs and things like that that will be put together, and we'll look at that. Again, the recommendation around the from VSP in terms of their vision coverage, the issue around expanding the benefit for Walmart was pretty straightforward. And the one issue that we need just to explore to a greater degree is what we just talked about, which was the retinal screening outside of a medical indication. So we'll get to that and bring that back to the next month's meeting. Any additional comments or questions from SEOW members or our PEB partners? Margaret, do you have anything that you wanted to add?
I do not. I've been taking notes, so we know where to head from here. Thanks.
Thanks so much. Okay, so I'm going to close the January SEOW meeting. Thank you all, folks. Bye-bye.
Happy New Year. Bye.